a few of these things from our adrenergic bronchodilators. So the first thing we want to look at with them is really we want to look at the definition of bronchospasm versus bronchoconstriction. So bronchospasm is going to look a lot more like the muscles going around the airways are going to be tightening down. Muscle spasm, so as they tighten down, you're going to decrease the lumen of the airway. Those are things that we treat, and we're going to treat with some medications we're going to talk about. But bronchospasm decreases the diameter. When you do that, you're going to increase airway resistance, so it's harder to get air through, and then increase work of breathing to offset that. It's going to decrease airflow down to the alveoli, and that's going to affect your oxygenation. So that's really how bronchoconstriction comes in, or bronchospasm comes in, I'm sorry. Bronchoconstriction is just decreasing the size. So constriction of the bronchioles, increase air resistance to, increase work of breathing, decreases the airflow down to the alveoli, can be from edema, so collection of fluid inside the membrane of your airways. Now, it's really, if you want to relate your airways to something, relate it to what your nasal mucosa is. Your nasal mucosa is identical to what's down in your lower airways. So think about that. When you get nasal congestion, you get that inflammation in those areas, you feel like your nose is clogged. It's because fluid is causing edema inside of your nasal passages. The same thing can happen down in your lower airways, which is much more detrimental down lower because you're going to decrease the amount of oxygen you get in. Of course, if you get nasal congestion, you'll just start breathing through your mouth, and then you can get oxygen down to where you need to go. But this bronchoconstriction comes from edema, also can come from secretions. So we produce 30 milliliters of sputum every day, no matter who you are or what you are. If you're a human being, you're going to produce 30 milliliters of sputum. Well, during times of infection or other exacerbations going on with the airways, your body can produce a large amount of secretion, so much that you can't get it out appropriately. Anything that's going to be in that lumen of the airways, so we have our broncho, I like to think of it kind of like muscles going around here. So the broncho spasm is those muscles closing down and then decreasing the size of the airway because these muscles are tightening down on this, and that's where your air is going through. Now, the bronchoconstriction, like let's say this is the lumen of your airway. Let's say it looks about like that. So we have air going through here. What can it be? It could be fluid causing edema to cause this to move in. So now you only have that amount of space. Or if you think of mucus can be stuck in your airways, it's going to decrease the size of the lumen of your airway. So the center of your airway is going to be decreased. So bronchospasm here, bronchoconstriction here. Bronchospasm is what we treat with our medications. So we'll talk about that in just a second. So the secretions, of course, bronchodilators do not work for edema. They do not work for secretions. They work for bronchospasm. So in our assessment is how we find out what the patient has and the responsiveness of bronchodilator therapy, which is really good to document when you're given a bronchodilator, let's say generically albuterol. You're going to listen to breath sounds, do a full assessment. You're going to give your a breathing treatment. Let's say it's albuterol 2.5 milligrams. It's a beta 2. We'll talk about that in a second. But then you're going to do a reassessment of your patient at the end of that. So you're going to reassess and see if the breath sounds have changed. Has the wheezing decreased, or does it sound like there's more aeration? That means you've been treating that bronchospasm. So they could have, and the majority of the time they have both spasm and constriction. So if you fix one, you got to fix the other. But if you release the bronchospasm, a lot of times, sometimes it might open the lumen up enough that you can clear secretions and whatnot. So just what we do with our assessments. So let's now talk about the receptors that your bronchodilators will be hitting on. So these are sympathomimetics. So it's going to mimic the sympathetic nervous system. Sympathetic is fight or flight. So that's your adrenaline rush. So it's going to, these things are going to mimic those. So alpha 1, this is going to be vasoconstriction. That's the main thing it's going to cause. So alpha-1 vasoconstriction, is that going to help me a lot? Not really. We're going to talk about a little bit with epinephrine, racemic epinephrine delivery, maybe for some kind of upper airway swelling and whatnot, maybe post-extubation. Beta-1 is another receptor that it could be stimulated. Beta-1 is really going to be a lot to do with increasing the heart rate and increasing contractility of the heart. So the way I like to kind of remember it is you have your two betas. Beta is your heart because you have one heart, and beta 2 is for your lungs, and we'll talk about that in a second. But 1 and 2, we keep it really simple. So increased contractility of the heart and heart rate. Is it going to help me any with bronchodilation? There might be a little bit, but it's not as refined as I really want. So hitting these receptors isn't going to help a lot. And when I'm talking about bronchospasm, these aren't going to help as much as this one. So beta 2 is actually, the receptors are present in the muscles that surround these airways. So there's our beta 2. So this is what we want to hit with our medications that we're going to be delivering. So our beta 2 agonist, so it's going to bind to those. It's mimicking the sympathetic nervous system, so sympathomimetic, and it's going to cause those muscles to release, and it's going to cause the muscles to let up, and it's going to increase the lumen of the airway. So beta 2 receptors are what we're going after when we're doing bronchodilator therapy. So let's get into the next part of this. What we're going to talk about is adrenergic formulations or adrenergic medications. Adrenergic medications are the ones that are going to be stimulating, that there's some pathomedics. So the adrenergic medications, that's really what the topic of today is. And the first used in 1900, epinephrine was first used in 1900, given subcutaneously for bronchospasm. So given just under the skin, was given systemically, it would have stimulated boom, 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 all these different things, but it would have also released, it would have bound to all these different receptors, caused all these things, but then you would have seen a the bronchospasm letting up, increase the lumen of their airways. So it would have helped with that, but it was kind of a generic way. It's like shooting a shotgun or something, you know, you're a large spread of what you're hitting, you're not directing at the target. So epinephrine is that, and epinephrine, what it is actually a catecholamine. So these drugs, the adrenergic drugs, I'm gonna make sure I spell this right. Adrenergic medications, there's two different types really. So they fall under catecholamines and non-catecholamines. So catecholamines, we're looking at epinephrine is our main one. So this is our shotgun medication. It's going to hit all those different things. It's going to stimulate all these different receptors here, and not really pinpointed in what you're going after. Alpha-1 receptors do cause a vasoconstriction though. So that's the one time we will give epinephrine and what's also called racemic epinephrine. So epinephrine is really like the starter medication, the top branch of all our medications. And as we get down to from the shotgun effect to more pinpoint targeting specific receptors, we're going to break it down. So we're going to refine each time. So epinephrine refined down a little bit is racemic epinephrine. That also coming out of epinephrine is isoetherin. That's another type of catecholamine, but it's just a refined form of epinephrine. Not super refined because we don't give this much anymore. It's not used for bronchodilator, bronchodilatory effect anymore. But these are just a couple of early medications that were used to stimulate this, which is our goal. But unfortunately, they stimulate all of them at once to do that. So, catecholamines, they're cool, but they've got a lot of side effects. So, What we really have broken our bronchodilators down to now are the non-catecholamines. So there's two different levels of those. There's resorcinols and there's acetogenins. Now, this is refining. So refined. We're getting down, or we're really going to be targeting those beta 2 cells over there. So those beta 2 receptors over there. So our non-catecholamines, of course, resorcinols is beta 2 preferred and can be given orally. So they prefer beta 2. So we're getting close now. And they can be given orally. We'll talk about this shortly. And then when we get down to our acetogenins, they're short-acting also, and beta 2 selective. So that's even more refined. And then beta 2 selective, and they're also short-acting. That's what we need in a hurry. Or they can also be long-acting. So either one, so short-acting or long-acting. But this is the most refined form of an adrenergic drug, is acetogenin. So we'll talk about those in a second. So this long-acting, of course, is always for maintenance, and we call short-acting rescue generically, because that's what we do. Maintenance and a rescue. You don't want to flip those two. That's bad. But there'll be tons going into that. So let's talk about some resorcinols first. So metoprolol and terbutaline. So metoprolol, I'm not going to spell that out. Metoprolol and terbutaline. These were given, I mean, it wasn't 15 years ago, they were given by respiratory therapists. And not really reformed, and you get a lot of this extra side effects that you didn't need, but they did work. So other names for those metoprolol, of course, Alupent, can be in syrups or pills, usually 5 to 15 minute onset, can last 4 to 6 hours, so it lasts quite a while. Terbutaline, also called Brethine, and it's actually still used, not in the nebulized form, but it actually, there's also smooth muscles in the uterus that increase contraction when a mom goes into labor. So you have the increased contractility of those smooth muscles down there. So terbutaline actually works really well on those muscles to slow or to stop labor. So maybe the mom's having contractions and the baby's premature. We want to stop labor. Brethine is a brand name. Terbutaline is a generic name of a medication that's given. But it used to be given for bronchodilation, but we don't do it anymore because we have more refined medications for that. So the acetogenins, the short-acting acetogenins, the big ones are, these are beta 2 selective. So these are preferential for beta 2, resorcinols are. Beta 2 selective for acetogenins. So like I said, refined and very refined. So let's talk about these medications. So these are our big ones that we're used to. So these are albuterol. Now, just because you give albuterol and it is selective for beta 2 doesn't mean you might get a little bit of these other ones, but it is selective to work right at those airways. So you could be hitting a little vasoconstriction, a little bit of heart rate increase, but we'll be monitoring that as a respiratory therapist who deliver this medication. So albuterol, Pyrbuterol, you won't hear much about this anymore. Brand name is Maxair. And levoalbuterol, levorotatory albuterol. It was really big a few years ago. It's still around. It's also called Xopenex. So if you want to look at the most refined acetogenin, it probably would be levoalbuterol, because what they did is they said, well, you know, we've done these catecholamines. We went from epinephrine, racemic epinephrine, non-catecholamines, resorcinols, terbutaline. We're going all the way down, breaking. So what levoalbuterol did was they actually took, there is an R isomer and an S isomer in albuterol, and they broke that out. The S was for the side effects. That's how I remembered it. And so this is just the R isomer of albuterol, is levoalbuterol. So it's really, really far broke down. They charged a bunch of money for it. Some people had side effects, some people didn't, but it does decrease side effects, but it's the cost is astronomical to albuterol when the effect is kind of questionable in a lot of circles, and especially in hospital world, because we're constantly monitoring the patients that are getting these. So just something to think about with that. So for the saligenins, also we have long-acting saligenins. So these are our short-acting. Let's see, short over here. My board's becoming a mess, but I'm afraid to erase because that thing was. These are long-acting. So long-acting is always going to be a maintenance type of medication. So let's think about them. Salmeterol is our big one. So Ceravent is the brand name for that, the most common brand name for that. Arformoterol, that is most commonly known as Brovana. It's kind of a newer medication. It works really well. And then you have, I probably should have put it in a different, Formoterol and Arformoterol are kind of very similar in the fact that this is brand name called Forudil, this is Brovana, so this is much newer. This is Ceravent. So these are all long-acting, selective beta-2 saligenins. So that's where that one breaks down. The other ones that I am not as familiar with, Indacterol and Olodacterol. So those are a couple other ones that are given in dry powder form, where Olodacterol is given a slow mist inhaler. I haven't seen a lot of that. Stiletto, we call it Stiletto, but it's really not called that. But that's the brand name for it. And then the last one that you're going to see a little bit is used in combinations, and it is, let me get this spelling right on this one, Glanterol. So that's another one that's used in some other ones. So you can see a combination. It looks kind of like an albuterol type thing because you end in the O. So there's your combination for the end of the suffix on all those. So long versus short, you got to know the difference. You got to know the doses on these because it's really important, especially for this upcoming test. So let's now talk about side effects. So side effects, think about side effects that you're going to have with epinephrine. So because that's really where a lot of this stuff, your side effects are just going to decrease as you go down to the more refined form. So tremors, of course, is number one. So due to beta-2 receptors that are in skeletal muscle, they're more common with oral agents because you're not delivering it directly to the airways. They're going to the stomach, getting broken down, they're going throughout the body. So you could have tremors from that, from oral beta-2s. Cardiac arrhythmias because of tachycardia. So that comes in where this little dude right here, this contractility, you could have some tachycardia, some arrhythmias from that. So your heart goes out of rhythm. Tolerance to bronchodilators. So repeat bronchodilators every single day. People may build up a slight amount of tolerance to them. So we try not to give the short acting over and over and over again. We really like to get into maintenance medications and look at other things, including steroids, which we'll talk about, which treat this dude right here. So this bronchoconstriction, that steroid goes right into that inflammation and decreases that. So that's what we'll bring these kind of back in together when we start talking about combination of medications. The CNS effects, of course, you're going to have headache, irritability, anxiety, insomnia. Think about that with, think about kind of what caffeine does to you too, because it's a xanthine, and we talked about xanthines a little bit in class, but these are going to work kind of on the same aspect of that. So make sure you know those side effects. Those are really important. Other things that are really good to know is how the medication is delivered. So is the medication going to be delivered through inhalation? So is it MDI, DPI, small volume nebulizer, or a slow mist inhaler, which is something If you're not familiar, if you've been working respiratory for a while, it is the CombiVent inhaler that actually is real slow. I should have brought one today to demo, but it's a Respimat format that it comes out of, and when you hit that, it actually gives you a slow mist. It's to increase the amount of medication that gets down to where it needs to go in the airways. Continuous nebulization, we do that with patients that are in extremis. So we're going to give a large amount of medication over a quick period of time to really flood all those receptors, to really try to open up their airways, especially if they have chronic bronchodilator use every day. They come into the hospital with exacerbation. It doesn't do it good to just throw that at them. We want to throw a larger dose at them where we're going to flood all these receptors and really try to open their airways up. So tablets and syrups, you'll see some used, not a lot, because your gut and your liver kind of break these things down. We really like to deliver it directly to the airways if we can, so that's why I prefer the inhaled method. And then IV, you will not see IV medications given very much from these aspects. There are some other medications that are used. We won't talk about them today, but when you give an IV epinephrine, that's exactly the same 1 milligram epinephrine as what we give in ACLS or PALS or NRP. This is medications that are going to increase contractility, vasoconstrict, and help to stimulate the heart, make it more susceptible to the defibrillations we're going to do. And so those are really code medications, that epinephrine you give an IV. So we won't be doing that a whole lot, I hope, for your patients. So that's a whole nother story on a whole nother day as far as ACLS goes. But there's some really important points for your patient assessment. So when you're delivering a bronchodilator, we look at a lot of different things. Like I said, the breath sounds and the heart rate. And one thing you want to really know about your heart rate is what your resting heart rate is before the treatment and then after the treatment. So a 20% increase is an indication you should stop the breathing treatment, because that means you probably stimulated too many of these dudes and maybe not enough of these, but we need to stop the breathing treatment. So let's think about this. So if we start with a heart rate of 85, 20% increase of that would be 102. So in the case if their heart rate starts to go 20%, 20% of it's 102. So anyway, if it goes up to 100, not quite there, but at 102, you would stop the treatment at that point. An easy way, that's a pretty good resting heart rate. Let's say the resting heart rate's 100. Of course, we want 20 in that case. So a 20% increase. So it's really key to know what a 20% increase from a heart rate is, because if you call a physician and say, I'm sorry, we had to stop this treatment early, you better have the 20% increase and what the resting was and what their starting was. Because for one, it just makes you know, you get on your medications well that you're delivering. We're not just throwing medications at patients because the doctor wrote the order to do it. I want to know exactly what this medication is doing down in the airways, and then what are the side effects, and when do I need to stop a breathing treatment. 20% is really important. So remember the 20% and figure it from 80, figure it from 90, figure it from 100, so that you have a good idea, or a 70 even, so you have a good idea where you need to stop treatments from the resting heart rate to the end heart rate. So we like to monitor heart rates during treatment is really ideal. So other things you look at are blood gases, pulse oximetry. You can look at that kind of stuff. Glucose and potassium, of course. Large amounts of albuterol can decrease somebody's potassium. Large amounts, and patients are affected differently. We commonly do get orders for albuterol treatments on people that are hyperkalemic, so high potassium level. Doesn't happen a lot, and I don't like doing it because it's like throwing a whole bunch of bronchodilation at them, but it will take their potassium down as needed, and then you find the reason why it was up. That's really the key. Make sure you're educating your patients, and then I always document a subjective response. So I ask them how they feel. How do you feel before the treatment? How do you feel after treatment? I think it's really important to document that, especially if you have a respiratory protocol, because you can document these different things and you have a trend of it, and it can give you an idea of, do we need to continue these treatments, or do we maybe need to decrease our frequency if you have that ability at the hospital you're working in. So that's kind of an overview of adrenergic bronchodilators. Like, comment, subscribe. Anything you want to throw in, there's probably some misspellings, but that's just par for the course. I'm just a respiratory therapist, and what do you expect?